All right. Well, like I mentioned, we are talking today about cardiac arrest and advanced heart failure and some of the therapies and current data around this medical conundrum, shall we say. The purpose of sort of or thoughts behind this talk is that, at least in the inpatient space, we're discussing code status. What does it mean to be resuscitated? What is it? What are the sequelae for people? Morbidity, mortality for people who have experienced cardiac arrest, and I'm hopeful that that we can learn a little bit and share some thoughts and maybe personal anecdotes. So I have nothing to disclose. Like I said, I'm a Corewell Health faculty for the Hospice and Palliative Medicine Fellowship. Our objectives today, so we're understanding the current state of cardiac arrest care and its implications in the palliative care space, gaining a basic understanding of advanced heart failure interventions, mainly focused on ECMO and its permutations. And then I'm hoping that we'll be able to describe the relevance of ECMO in the palliative care space. So as per usual, we'll start with the case. So this is a real case, 63-year-old female who I saw in fellowship. She had a history of pulmonary sarcoidosis and was hospitalized for acute hypoxic respiratory failure. Unfortunately, her condition worsened and she had a respiratory-induced cardiac arrest. Underwent several rounds of ACLS, was intubated, and they got her back. Unfortunately, she was in persistent cardiogenic shock. They were having difficulty maintaining her saturations, and so they quote unquote crashed her on ECMO. And this, she was able to be stabilized with this intervention. She was able to be weaned off pressors and ultimately extubated. However, she was left on ECMO to facilitate lung transplant. So she was waiting on the circuit. And we'll come back to this case a little bit later on. So that's a lot of data already. And so just an aside, I love Google stock images of medical professionals, and this guy jumped out at me when I Googled befuddled physician. So I think we need to step back before we sort of dive in, just to get a lay of the land as where we stand currently with cardiac arrest. I mean, hundreds of thousands of people experience out of hospital cardiac arrest and every year. And it wasn't until fairly recently that data started being collected on these individuals. Like, what happened? What interventions did they receive? How many people made it to the hospital alive? And it wasn't until 2004 that the CARES, the Cardiac Arrest Registry to Enhance Survival, was founded by the Institute of Medicine and Emory University Emergency Medicine Department. And they started capturing these cases. The first year they registered 600 cases. Flash forward to 2022, they're capturing 2,800 cases weekly of out-of-hospital cardiac arrest. And really sort of the data has just exploded. It started, like I said, in Emory in Georgia and has expanded nationwide. Michigan is the state that participates in this data collection. So you can go on the Save My Heart website and download the raw data yourself, either from the past year or years previous. Again, I love stock imagery. These people have definitely not experienced cardiac arrest, and their skin is perfect. So some data. I promise it gets less data heavy as we go on, but I think it's important to know where we're starting from. So the current state of cardiac arrest. So from 2013 to 2022, the CARES network recorded 876,000 cases of out-of-hospital cardiac arrest. 46.2% of these people received bystander CPR. The survival rate for all comers was 9.2%. So not great, but I think, again, in the palliative care perspective, important to think about these things when we're talking with our patients. And what does survival mean? Survival means survival to hospital discharge. There's an asterisk next to that, and I want to focus on what that is. So this is what a report looks like. It's a busy slide. I'm not expecting anyone to be able to read these things. I'm going to blow up what I think is important. So this is Michigan, and this is Michigan over in the calendar year 2022. So lots of data, but zooming in here. So we talk about survival, meaning surviving to hospital discharge. So you got to make it to the hospital alive, which is 24.6% of the recorded 9,000 patients or so. Survival to discharge for these patients is only 6.5%, which is, not again, kind of discouraging numbers. I think it gets even more discouraging when you say, you may be able to read this. It says survival to discharge with the CPC 1 or 2. And CPC is a measure essentially of disability. So a CPC 1 is no disability. You walk out of the hospital. A CPC 2 is moderate disability, and that might be physical or neurologic disability. CPC 3 is a significant disability, and so that is a not insignificant population that who may survive an event like this. Those who survive with significant disability. So 6.5%, again, these numbers sort of in the back of your mind as you're talking to your patients, only 6.5% for out of hospital cardiac arrest and survive to the hospital discharge without severe disability. So this is a bummer, man. And I'm afraid that, the numbers have not changed much over the past, 30 years or however long they've been recording this data. So what works? What do we know that works for these patients? Well, early CPR and defibrillation. In the medical field, most of us are trained in BLS. Many of us are trained in ACLS. And the evidence strongly supports the use of early CPR and defibrillation. It's a class 1 recommendation by the American Heart Association. This is why there are defibrillators at McDonald's, in the airport, at Myers. Because the evidence so strongly supports early access to defibrillators. So the only rhythm-specific therapy proven to increase survival to hospital discharge is defibrillation of VF or pulseless VT. So what else? Epinephrine. If you have been lucky enough to be involved in a code, 1 milligram of epi every 3 to 5 minutes is a part of the ACLS algorithm. It's only a class 2B recommendation, so evidence is not super strong, and we're going to get into that a little bit, but the American Heart Association guidelines say that it may be reasonable for patients in cardiac arrest to get epinephrine. And this is based on, spoiler alert, there's a lot of sadness in this lecture, and I apologize to start the day off with a bummer, but this is the data that the epinephrine recommendations is based off of. It was a 1960s study using beagles, where they induced cardiac arrest in these poor beagles, and then provided them with ventilation, compressions, and epinephrine, and all of the dogs who were randomized to the epinephrine arm achieved ROSC, or return of spontaneous circulation. So it's been a long time, since 1963, and so in 2018, a study that was called Paramedic 2 revisited the evidence for epinephrine. It was a randomized controlled trial where patients were provided with placebo versus epinephrine, and this is what we found out. So survival was better in the epinephrine group, the authors found, better than placebo, significantly higher 30-day survival, but no significant difference between the groups regarding favorable neurologic outcomes, because more survivors had severe neurologic impairment in the epinephrine group. So it was, getting epi increase your chances of survival, but also significantly increased your risk of having a severe neurologic impairment. So getting into some very rudimentary anatomy and physiology. This is a crude cartoon of the normal human circuit, the cardiopulmonary business. And so on one side, you see, this is the heart and lungs. At the top, you have the right atrium, to the right ventricle, to the lungs, to the left atrium, to the left ventricle, the aorta, which provides perfusion to the tissues. And then all that blood comes back through the IVC or the SVC. And this is the SAD circuit, okay? A lot of potential breaks in the chain can cause collapse of, hemodynamics and cardiopulmonary stability. So what if we could bypass a broken circuit? Well, that question was asked by some physicians in the early 1950s, right here in Michigan, actually, in Harper Hospital. They successfully performed the first cardiac bypass using an external machine that was made in cooperation with GM, of course, GM engineers. And it's maybe hard to see in this photo, but it doesn't seem like an accident that this device that these guys are standing around it looks like it has 6 cylinders. Like, it looks like a V6 engine to me. But this is a big deal. So the headline is, first time robot heart keeps man alive here being Detroit. So go Michigan. So I want to talk about ECMO, which we'll get into, because that's sort of the evolution of what we're looking at here. But I think it's important to just get a very basic understanding of what other interventions we have for these injured circuits. If the heart is not working well, we're brought to the bedside, and these people have a lot of medical complexity. And so I think it helps to define a couple of terms. LVADs, or left ventricular assist devices. This is an important thing for palliative providers to know about, because if you're at if you work at a center or a clinic that serves patients with LVADs, there are centers where people who receive these devices are automated to get a palliative care consult. and this is a JCO mandated thing or Joint Commission mandated thing. And so, what is an LVAD? Essentially, it is a cardiac output booster. There's an internal pump that's powered by an external battery pack. So there's basically an electric cable that goes through the skin into this and feeds power to this pump, which sucks blood from the left ventricle and pipes it into the aorta, sort of bypassing a sick heart. You may or may not have heard of an Impella device. A sick patient in the hospital who is experiencing fluid cardiogenic shock. Again, these are kind of all booster devices. So this is a catheter that is usually implanted in the femoral artery in the groin, fished up, snaked up through into the aorta. And ultimately the tip rests in the left ventricle. And it has an intake and an output, basically lumen, and it slurps blood from the left ventricle and forcefully pushes it into the aorta to increase that cardiac output. Typically, it's not something that someone goes home with, at least and not in my experience. And then the last device I just want to bring attention to is the intra-aortic balloon pump. A little bit more complex, I guess, in that it's a balloon that is sort of snaked through the descending arch of the aorta and inflates in diastole and deflates in systole. And really, the sort of quick and dirty version is it's, again, designed to increase cardiac output by shunting blood to the coronary arteries, increasing the coronary artery perfusion, and the hope is that more perfusion to the cardiac muscle improves cardiac output.
Amazing.
Did someone have a question? I heard someone on the call. So ECMO, the patient that we talked about in our case was crashed on ECMO, and it is a bypass machine. The other interventions that we mentioned are kind of cardiac output boosters. This ECMO replaces the function of the heart, replaces the function of the lungs. And so there are two flavors of ECMO that I want you to know about. VA ECMO is a heart and lung bypass machine. So it replaces a sick heart and sick lungs. It does the pumping and the perfusing. So blood goes through the ECMO machine. It receives oxygen, and it also has pressure, a higher pressure system to take over basically the mechanics of a normal pumping healthy heart. Whereas VV ECMO is just blood oxygenation to bypass broken lungs. So there was many attempts to save sick patients with COVID whose lungs were shredded with fibrosis or ARDS, try to sustain them on VV ECMO to varying levels of success, just how sick those patients were, that they didn't do very well. So what is ECMO? It stands for extracorporeal membrane oxygenation, and I told you a little bit about the differences between VA and VV ECMO. VA ECMO, primary cardiac failure, cardiogenic shock, pulmonary hypertension, or somebody who is desperately needing a heart transplant and they just need a little bit more time to get there. Versus VV ECMO. Think about, pulmonary failure, pneumonitis, people who need a lung transplant, or have, a terrible trauma to their airway, and there's no other way to, oxygenate these folks. This is the case that I brought up. The patient was on VA ECMO. They did have pulmonary sarcoidosis leading to respiratory arrest. But then suffered cardiac arrest, so it was they got the VA flavor. So this on the photo on the left is a patient being cannulated for ECMO. So it looks pretty messy, pretty chaotic, and you'll find out more why in a second as far as this photo. But you can see the two garden hoses going into, I guess, what the patient's groin, and it looks like it's already kind of flowing there. And then on the right is something that you might actually see at the bedside, the circuit running. And what is the circuit? I don't want to get too much into the mechanics of it. I think of it almost like a dialysis machine, except, blood goes in, blood goes out, and the blood that comes in is deoxygenated and has higher levels of CO2, and that's the blood is passed through a membrane that provides oxygen to it and removes the CO2, and then it's pumped back into the body. So those cartoons that we looked at before, the injured human circuit on VA ECMO, from the top, you see the femoral vein, the cannula that goes into the femoral vein. That's the outflow track that goes into the ECMO. It gets it's deoxygenated blood, it gets oxygen, and then the femoral arterial line goes back into the body to provide that oxygenated blood to the rest of the body. It's a little bit backwards. Some of you might have noticed already that, well, why is blood going into an artery from an exterior source able to get, the femoral artery? How are we able to get oxygenated blood from the femoral artery to the brain? Well, the answer is retrograde flow. So it's high pressure. It pushes against the femoral artery, the pressure, and gets up to the aorta and brain and all the vital organs that way. So why do we use ECMO? What's the rationale? So it is being used for refractory cardiac arrest, and the data is encouraging. We saw how abysmal our survival rates for the practice that has been in place forever, ACLS. There have been several studies in the use of ECMO that have shown increased survival rates, some modest, some significant, but the jury's still out whether how beneficial as regards to how beneficial it can be. It's a hard patient population to capture in terms of data. People who suffer cardiac arrest outside of the hospital. But this is the zoomed out photo of the ECMO cannulation that I showed you a couple slides ago. This patient is being crashed on ECMO in the metro in Paris. Out of hospital ECMO is a thing, and it's happening mostly outside of the US. Almost entirely outside of the US. So Paris being one of the places that is doing this with increased frequency. Pretty wild. So a lot of talk about ECMO. What are the considerations that we need to think about in the palliative space? Like all patients with cardiac arrest or cardiopulmonary shock, the mortality and morbidity is extremely high. So despite these, highly technical Hail Mary interventions, most of these patients die in the hospital. As far as 63% is the number. And so there are multiple centers around the country who provide ECMO therapy, who automatic trigger palliative consults for these patients. Not only because of the high risk of mortality, there's also a high associated morbidity. So these people need to be super anticoagulated, which puts them at significant bleeding risk. The pumps can clot, and they can experience a pump circuit failure. When you're cannulating a femoral artery and you are pushing blood backwards, well, it's not hard to imagine that the leg might have something to say about that. And so you can have critical limb ischemia. You can have neurologic injury, which in this patient population, they may already have a previous neurologic injury from their state before they received ECMO. And then anytime there's something outside of the body going in, the risk of infection and pain. So back to our case, what happened with our lady on ECMO? So she remained on ECMO for several weeks while she was awaiting a lung transplant. During the 5th week of her hospitalization, she had a hemoglobin drop. Went down to CT and unfortunately had a large retroperitoneal hemorrhage that was found. They consulted IR to possibly embolize this bleed, and they said just leave it alone. This would sort of taper off on its own. Unfortunately, the significance of this bleed bumped her off of the lung transplant candidate list. She was no longer a candidate for lung transplant. And to make matters more complicated, ECMO is not a destination therapy. It is a bridge to something, transplant or wean of ECMO, or maybe an LVAD implantation, something like that. She didn't have any options for a destination therapy. And as ECMO is not a destination therapy, she was informed that it was no longer an option for her. As you can imagine, that is a very devastating conversation to have. It's, this thing that is potentially keeping someone alive is being taken away. So there was a big family meeting, and it was decided to discontinue life-sustaining therapies. She was transitioned to comfort care, and the ECMO circuit was turned off, and she passed away within about 20 minutes with palliative providers at the bedside.
John, just a quick question on who negotiated that conversation. Were the surgeons or the critical care folks, or did they default to you to do that, or how was that conversation?
It was primarily, ECMO is owned by CT surgery in the vast majority of cases, or the cardiothoracic ICU folks. And so that conversation very much was led by those folks with palliative presence to provide additional support. But yeah, it was a notable case. I'll never forget. Yeah, because she was awake. Sometimes these patients are on a ventilator as well. She was not. She had been extubated and was fully cognizant. And so, yeah, raised a lot of questions and obviously a very emotional case. And how do you talk about, I think this is an important topic because these advanced therapies change the vocabulary, at least, introduce things that many of us haven't really thought about before. How do we define death when cardiac, when we're bypassing a non-functioning heart for somebody who is sedated and intubated? And I'm reminded of The Princess Bride, one of my favorite movies, Miracle Max, saying there's a big difference between mostly dead and all dead. Mostly dead is slightly alive, which is sort of how some of these goals of care conversations have felt. In the background here, there's an EKG. This is from a patient, one of the most recent patients I took care of, who was on VA ECMO, and he had basically absent cardiac function. This is a PEA arrest as we define it, like pulseless electrical activity. And so there's a little wiggle there to the ECG tracings, but that heart is not doing really much of anything. I mean, we looked at the echocardiogram, and it was basically in stasis, just like a little bit of twitching with systole. And so how do we bring this data as medical people to the table when we're talking to families, when we don't really fully understand what we're looking at? How do we expect our patients and families to understand the level of complexity, the sort of medical ethical questions that it brings up? It's pretty humbling stuff. So it's a big topic. I think there are many more conversations about ECMO in the palliative care patient population. These patients were palliative appropriate prior to receiving these interventions, and given the significant risk of death and disability from receiving these interventions, palliative is going to have an increased role at the bedside for these patients. I wanted to wrap up with another photo from Paris. This is the Louvre. Some of you may have been there. This is a patient. This is not an art exhibit. There are art exhibits in the background. This is a patient being crashed on ECMO in the Louvre. And I suspect that given the promising data that we're seeing from this intervention, we're going to see more of this. Are we going to see it in Grand Rapids? Maybe. I think that day is pretty far off, but I think we have a responsibility to know about what's out there and to know how it impacts our practice. And that is my talk. Appreciate your patience and attention, and I open it up to any questions, any comments. The floor is yours.
Very, very interesting stuff, John. Appreciate you sharing that. And that I don't remember seeing that when I was at the Louvre, so I appreciated that. You can't see everything when you're there. It's a large
right. Right.
So
it's hard to cover it all.
I kind of missed that particular one, but fascinating what they're able to do out in the field these days. And I'm just kind of curious with that. are those physicians that then are dispatched with the EMTs? I mean, Ken Hansen's sitting here and he is one of those guys, palliative and ER and EMT. And how does that happen?
Well, they call it the Franco-German EMS system. It's typically physicians that are dispatched. So the Royal, I can't remember what it's called, the Royal Life Flight of London is also doing ECHO. And there's actually, I don't know if it's 2020, but poor lady's riding to work on a bike and gets plastered by a truck. And they film how the helicopter lands and they do ECMO right there on the street corner. You know, I think that's what they did.
So that would require a substantive change in the infrastructure of our EMS system.
Yes.
Because we don't have docs.
Because Reagan, it was federally funded until Reagan got in office and did away with all that. And then he pushed it back to the states. So right now you have, the joke is if you see one EMS system, you've seen one EMS system. It's different in sometimes every county. And there's been state drives to kind of have state protocols like we do in Michigan. But the state protocols here are advisory. You can really pretty much do anything you want in the MCA, you know, as long as you can support it. But for the most part, people follow them. Yeah. I'm just thinking of a case report I read where I think it was in San Diego. Patient on LVAD on destination therapy walked into the ER in VFib arrest. And they wrote this up, and it was kind of like, what do you do? I mean, if you can't get his heart restarted, do you send him home? Do you admit him? What do you do? It was just, you know, I don't remember what happened, to be honest with you, but it was pretty, I mean, the guy's walkie-talkie and VFib arrest.
Yeah, that seems incongruent.
I'm about to work in overtime.
Well, I would have liked to seen
Put a new EKG.
the triage nurse. Yeah,
New lead, just try again.
the triage nurse who does the EKGs, like what?
So well, I'm curious, John. I know that in the early days of LVADs, you know, the outcomes are certainly much better now. They really didn't have bridge LVAD. I'm sorry, they didn't have destinations. They were all considered bridges, and yet people would be on them longer and longer, sometimes with complications. And because of the rigidity around the expectations of why we were doing LVADs, patients had their advanced directives, DNRs and such suspended for a period of time. And it made it very difficult when someone had a potentially, you know, they have a massive stroke in the midst of having their LVAD. They were not going to recover from the stroke, and yet the LVAD continued. Are we seeing moves to be more flexible and allowing folks to back out of the interventions when they find that the burden of them is greater than what they anticipated?
You know, I don't know if this is a dynamic. This is a good question. I don't know if this is an LVAD specific dynamic. I mean, I think there's similar implications on transplant recipients. You know, people who have been transplanted with hearts, lungs, kidneys, other vital organs. I think that you know, part of the LVAD evaluation is, or transplant evaluation is, making sure that these people are going to be good stewards of you know, life-saving resources and highly, you know, limited resources in this regard. And so I have not seen a lot in my, you know, few years of practice of these questions coming up in terms of, well, revisiting their goals of care when they've received this highly sought after intervention, life-sustaining intervention, and have a change of heart or change of, no pun intended, they feel differently, their goals change. If there's pushback to that, I have seen some resistance by by the primary teams taking care of these patients to discontinuation of life-sustaining therapies. I mean, they're highly invested in these patients, and they put countless hours and a lot of efforts into rescuing them from the brink. And so highly complex goals of care conversations in that regard. But as to your question, I'm not sure. I'm curious if other people have experienced that dynamic.
Others? Questions?
With regards to some of these therapies, I've always had the thought of what's going to happen if this does become more available, especially with centers doing ECMO now in the ED, run by the ED docs. And if there's going to be a creep towards doing this more and more and more, and just to get them out of the ER and then have some of these conversations in the ICU level of care. And so it raises a lot of issues of, should we be placing some of these decisions on families? Should we be doing this to begin with? And where are the criteria and how are we defining that very specifically? It just seems like the trend of dialysis now has been pushed further and further into the later stages of life. And I just wonder if this same kind of thing, that we have the interventions, if we're going to use it indiscriminately, and how do we kind of step back and carefully utilize those resources?
I like what you say, because if this patient receives standard resuscitation and after 20 minutes of CPR and all of that, they don't get ROS, what do? They terminate the resuscitation. What's that patient going to do? Right? They're going to the hospital, right? And they're going to be, like Dr. Abrams said, a little bit alive, right? Mostly dead, right? And it completely changes the paradigm. What do you do with that? Because now most EMS systems will not transport, patients unless they get ROS, return of circulation. So it's called in the field, so it never even gets to the emergency room. And so I've always said that, care by pre-hospital often drives what happens in the ER, which then drives what happens in the hospital and further on.
Well, and the tendency to indiscriminately apply technology because we can and because it's available. John showed us the statistics at the beginning about failure rates, or I guess maybe we should look at the positive side, survival rates of those receiving, CPR in the field versus in the hospital. But I got to believe that the likelihood that someone receiving ECMO out on the field surviving to discharge, that's got to be pretty darn small.
And like we talked about last time, what about the ones that survive but are neurologically devastated? Because they've done 20, 30 minutes of CPR before they actually get them on the circuit, and they're now, irreversibly damaged.
I guess we don't have all the answers yet. It's likely to become even more dicey. Well, I'm glad, John, that they're including palliative in those conversations. It's nice in the hospital where you can have those, but this pushing upstream of these sorts of aggressive interventions, I don't know that we have the data to suggest that that's a good thing or not.
I think how abysmal are how the state of cardiac arrest care has been for virtually ever. It's hard to imagine it being worse, but agreed with others' comments. It's like, well, what do we define as better? When the ECMO patients, 6 out of 10 of them are dying in the hospital. It's a pretty humbling. I think continuing to work with the providers who are at the forefront of this intervention and collaborating with them, getting to the bedside earlier, I think can only help, and becoming more fluent in this intervention and the potential complications and suffering that these patients and their families may go through. So, well, thanks again. Appreciate the discussion.
Well, thank you, John. I appreciate you presenting.